Mingla Siaro, Gulo Chain Gabriel, the webinar day or la Jesutimare, General Namia, Sunny Tintuama, General UK Royal College of GPA, the webinar or General Royal College of GPA, Myanmar GP Education, yeah, Royal College of Pediatrics and Child Health, the Trebi Lote webinar. General Gu, Timpiama Siama, Mesa Kerry, if you could do the introduction, please. Thank you.
So today, Dr. Taryn Gaunt, who's a family doctor from South Africa with lots of experience in rural medicine and specifically TB, is going to give us a talk today. So if I can introduce Taryn and get started.
Excellent. Thank you, Caroline. Thank you, Dr. Sonny. And thank you to everybody who's given up some of their time to listen to this talk. I am going to be talking a little bit about pediatric TB in a rural setting in South Africa. I really hope that this is relevant to you all, and please just tell me if I must slow down. I have a habit of speaking really quickly. But yeah, let's get started. I hope that we can get through as much as possible. So I'm going to just go through some of the really obvious stuff that everybody knows already, but just as a reminder, because I think it's helpful when you get to the clinical things. This is the talk that I've presented to our doctors at our rural hospital every year for the last 8 or 9 years. And so yeah, I just thought I'd just adapt it and then see where we go from that. So just to remind you that TB contact is any person who's been exposed to an index patient. A household contact is what is particularly relevant, and that's somebody who's shared the same enclosed living space for at least 8 continuous hours, or it could be more frequent, prolonged periods. And it's usually within 3 months of the index case becoming ill. The index case is the first person to be diagnosed with TB. And obviously when it's a child, that's the first person, that is your canary, because a child isn't the one to first get infected in that household. Someone else is probably sick in that household. Okay, so there are 3 factors that determine the likelihood of transmission of tuberculosis: the number of organisms expelled into the air, the concentration of those organisms, which is determined by the size of the space and how much ventilation there is in that area, and then obviously the length of time of exposure. So
Taryn,
I think you all
could you
know
speak up a bit? Sorry.
Okay.
Could you speak up a bit? Thank you.
Okay, so one cough can produce 3,000 droplet nuclei. And just to remember that a sneeze can produce a whole lot more nuclei, okay? The most infectious cases, as we all know, are your smear-positive pulmonary TB cases. But smear-negative cases can also be infectious. They're much less infectious, but they can be infectious. Extrapulmonary TB, however, is almost never infectious. And this is really relevant when you're presented with a child that is exposed to somebody with TB, and then you find out that they've got TB meningitis or TB of the bone. The child is very, very, almost never likely to have got the TB from that person. Can you hear me better now?
Yeah.
Thank you. Okay. Once the infection is in situ, it progresses to active disease, depending on the immune status. Okay, I think we all know that most people with normal immunity will not progress to TB, but 10% of healthy people will. However, in our HIV positive community, 50 to 60% of people who become infected will go on to disease. Okay. The risk is highest, and this is relevant again, especially in children. The risk is highest in the first 2 years after infection. Half of the cases that you're going to see have been exposed within the last 2 years. interestingly, that does mean there's another half of the cases who then will present later on in life when their latent TB becomes reactivated. This is particularly relevant if a child becomes immunocompromised, and we'll talk later about some of those conditions. And then there's a period in your mid-teens, about age 13 to 14, where your immunity drops a little bit. And again, you're vulnerable and you might reactivate your latent TB then. Okay, other factors that have been shown to increase risk of transmission. I'm not sure if cooking fumes is relevant in Myanmar, but this has been shown to increase your risk. Was a positive effect in the studies, but not statistically significant. However, a damp environment indoors was shown to be statistically significant, as well as, we all know, overcrowding. Okay, so these are the things that can reactivate a latent infection in children specifically. Something we all see a lot of, I think, malnutrition, and then measles. So a child who gets a case of measles, you really want to watch that child for TB afterwards. And then whooping cough. Just to remind everybody, I think we all know that BCG provides some protection against active disease, but mostly its action is to prevent some of the severe forms of TB, like TBM and miliary TB. And even there, it's not all of the TBM and miliary TB that is protected against. We recently had, with COVID, we had stockouts of BCG in South Africa, and we saw a peak of the cases of TB meningitis and miliary TB in our young children. So it really does help. If anyone has any questions, will you please let me know. Okay, I'm still just the basic stuff. Primary infection, that usually happens in childhood in cases where there's a high incidence of TB. The TB gets to the terminal alveoli of the lungs, which is usually the lower part of the upper lobe or the upper part of the lower lobe, that middle area. The TB bacilli gets phagocytosed by the alveolar macrophages, and then they replicate inside those macrophages. There's then an immune response, and the bacilli get eaten up, and the area forms something called a Gaunt focus. And then the bacilli and antigens will drain from that Gaunt focus into the lymphatics, usually in the hilar lymph nodes. And together, this Gaunt focus and hilar lymph node infection is known as your Gaunt complex or your primary complex. This primary focus contains between 1,000 and 10,000 bacilli, and they gradually lose their viability. There's some dormant bacilli in the primary focus that will then go on to survive for months or even years, and that's what becomes known as your latent TB. It's very important to notice that you don't have an immediate immune response to the TB, that it is a delayed response, and it takes up to 4 to 6 weeks post-infection for you to see a positive skin test. I think we often are seeing children earlier than that in terms of infection, and we are then excluding TB because the skin test was negative. But we must remember we might need to repeat that test, or we might need to keep looking if the child was exposed in a shorter period than 4 to 6 weeks. Okay, so most children acquire TB from infected adults. As I said, they're the canaries. They don't get it from each other, and very seldom does an adult get TB from a child. Our malnourished children, our immunosuppressed children, and children under 3 years of age with pulmonary TB are all considered to have serious TB. Okay, so in the South African guidelines, and this is based on the WHO guidelines, the diagnostic criteria are as follows. Any child who presents with symptoms and signs suggestive of pulmonary TB is regarded as a case of TB if there is any one of the following: a chest x-ray suggestive of TB, and or a history of exposure to an infectious TB case, and or a positive tuberculin skin test. I'm not sure what you use in Myanmar. Do you have the Mantu? Do you have Mantu?
We use just H3 and H3 tuberculin that I'm not much more practice of.
Okay. Okay, well, I'll just talk a little bit quickly about that then if it's not so relevant, sorry. Okay, just quickly go back to the signs and symptoms of TB. So obviously, as I said in the previous slide, it's signs and symptoms of TB plus one of these other three things. So the signs and symptoms of TB are an unexplained weight loss or failure to thrive. And this is why we really need to have our weight plotted, and we need to know what's been going on over a longer period. And we need to watch carefully for when the weight drops. And the one that we more subtly miss is the failure to thrive. And then an unexplained fever of more than 14 days. And I always remind my doctors to look really carefully for this. I always pull out my pink highlighter and I go through the notes and I highlight every temperature that I see elevated. And it really does help to give you an idea. And just a reminder that trying to diagnose TB in children is all about the whole picture. So you want to try and get as many clues as possible, and an unexplained fever for more than 14 days, you really do sometimes have to go look for. I don't know about your context, but in our context, the whole idea of night sweats is fairly common. A lot of people share the same bed. They have to keep the windows closed at night during summer because it's not safe. And so you really do actually have to physically go and look for those unexplained fevers and night sweats. And then a chronic unremitting cough for more than 14 days. There are a lot of people who get post-viral coughs, and they might fit into this category. But what you specifically want to ask is whether the cough is the same or whether it's improving. If it's improving, it is not a symptom or sign of TB. Okay, and then lymphadenopathy, especially your cervical lymph nodes, and just to note that those are often matted lymph nodes. And then hepatosplenomegaly, and obviously consolidation and pleural effusions. And then just to remember, it's not part of the symptoms and signs specifically, although I think in the newer guidelines, it is being included, reduced playfulness. Children play, that's their work, that's what they're meant to do, that's how they are programmed. If a child is not playing, you really need to think carefully about what's going on, and you need to make a plan if they have decreased playfulness. Might be nothing to do with TB, but it still is a red flag and you need to look into it. Obviously, if they have the reduced playfulness, as well as a chest x-ray suggestive of TB or exposure to TB or a positive skin test, then you can maybe go down that road a bit further. Okay. TB may be evident on the chest x-ray, and I'm hoping to get you some chest x-rays at the end of this. You might see direct evidence of hilar or mediastinal adenopathy, or you might see indirect evidence, much more likely that you'll see the indirect evidence. And this is with or without parenchymal opacification. Remember that with the Gaunt complex, it's the lymph nodes that you're seeing. You might also see a bronchopneumonia, and then the children with miliary TB, you will have miliary changes, and less likely, but something we do see is pleural effusions. Okay, the tuberculin skin test, which is what we do in South Africa to look for exposure when it's in stock, which it often isn't. It's 0.1 ml of your PPD injected intradermally. You read it after between 48 and 72 hours. And then we have to read the transverse diameter. And then I always just want to remind people that once it's positive, the kindest thing you can do is give some steroid because it really is painful. A TST may be falsely negative in the presence of malnutrition, immunodeficiency, HIV and AIDS, immunosuppression, a child is on steroid therapy or cancer therapy, and then following overwhelming viral infection, something I think we've seen a lot of in the last few years, especially with measles or even just post-vaccination. If we do see that, then we accept a smaller number of the induration. So more than 5 is regarded as positive. But it's important to remember that you may still even get a negative test, in which case you need to just keep looking and keep thinking. Yeah, I won't even talk about this. But yeah, just to say, specifically, if you just look at the last point in miliary TB and TB meningitis, only 50% of cases have a positive TST test. So you might still be missing a whole lot of cases. Okay, then the gold standard is to look for, is to look for TB on microscopy or, more importantly, culture. So you want to do an early morning gastric aspirate. Again, are you guys able to do gastric aspirates? Dr. Hein, are you doing gastric?
I wouldn't have thought so. Not in general practice in MR. It'd probably be sputum based.
Okay. If it's possible to access some sort of suction machine, it's really easy to do a gastric aspirate. You want the child to be starved. So in a smaller infant, it's no food or oral intake for 4 hours. And you literally are just suctioning the stomach and then adding a little bit of sodium bicarb. And we do that because we're usually far away from the place that's going to do the test. And then we send the test off and they are then able to culture it. Otherwise, as you said, sputum is actually the better option. In an older child, you can just ask them for a sputum. In a younger child, they recommend that you do an induced sputum. In our setting, trying to do a saline neb, which is what is recommended, was really difficult. So I started advising my children to go for a run. I would set up a little obstacle course, get them to jump, get them to move around, and really be a little bit busy, and then inevitably they start coughing. But before any of this happens, mom's got the sputum jar in hand and she's ready to catch it. If you've got a child that's admitted, just give the mom a sputum jar as she walks in the door, because I've seen babies cough, 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 and then spit onto the pillow, and she can literally just scoop it off the pillow and send off that sputum, and you might get a result from that where you've been hunting and hunting and hunting. Apparently, there's a high level of culture positivity in CSF. That is not something that I've seen, but yeah, maybe you guys see that. For your pleural anesthetic fluids, again, a low yield in terms of culture. However, if you get a pleural ADA that's more than 40, this is highly suggestive of TB. And then fine needle aspirates of any lymph nodes. If you have access to that, that's really helpful. A child with chronic otorrhea, if you can send an ear swab off, that might well be the reason for their chronic otorrhea. We've diagnosed several children with TB from ear swabs. And just to remember, if they've got otorrhea and they've got a facial nerve palsy, that's almost pathognomonic of TB. You can take that as a symptom or sign and possibly even start treatment. At the end of the day, we do all of these things, and yet the guidelines are clear that most children will not have microbiological confirmation of TB. And that's why TB at the end of the day in pediatrics is about the picture, the whole picture. Okay, you want to do a PCR if you can. It's going to give you an inferior yield to the culture. So don't replace it with the culture. If PCR becomes available and it wasn't available before, do it, but remember that culture is still going to give you a better yield. Yeah, obviously with the PCR, what's really nice is it's just a quick turnaround, and you also, from the get-go are going to know if there's some resistance. So in South Africa, the first PCR they do immediately shows the rifampicin resistance if it's there, and then there's a second test that they'll do straight away on that to see if there's second-line resistance. But again, just remember that microscopy and culture, and specifically culture, must be done on all cases. It's going to give you a real answer at the end of the day. Okay, so culture is gold standard. It takes a long time. It's 3 to 8 weeks. And again, that's something I have to keep reminding my team, that once you've taken a culture, highlight it somewhere, make sure it's written clearly so someone else can follow it up. And then as the doctor following up, make sure you look back in the notes and find when the culture was done and that you do follow that up. A culture can detect as few as 10 bacilli, which is a really amazing yield. 25% of children with confirmed culture positive TB had negative PCRs in one study in South Africa. It's better to do 2 specimens if you can. You get an increased diagnostic yield. And if you're going to do a gastric aspirate, you can repeat it between 8 and 24 hours later, so you can get your 2 specimens. And an induced sputum is obviously going to be better than a gastric aspirate. Nasopharyngeal aspirate, something that was popular in the past, is really not recommended anymore. The yield is very low, so don't do that. And there's quite a bit of promise in the whole urine culture arena. So yeah, watch this space. Maybe that's something you guys already have, I don't know, but that'll be amazing when we've got that available. And then there's also the stool culture, which has come in South Africa and is being used in some areas to confirm TB. Okay, urine lambs. So this is the WHO recommendations, and they suggest that all HIV positive children who are admitted must get a urine lamb if they are under the age of 5. If they're over the age of 5, but they have a low CD4 count or stage 3 or 4 HIV disease, they should get a urine lamb. And this is without signs and symptoms of TB. So that's maybe something to just think about in your admission criteria if you are sending children to a nearby hospital or you're involved in a hospital. Okay, in South Africa, we have 3 different regimens in treating pediatric TB. The guidelines are in the process of changing, so I'll just quickly go through this. It's mostly just remembering the different types of TB you get. So regimen 3A is to treat uncomplicated TB. It has been traditionally 6 months of treatment, but is about to drop down to 4 months of treatment. And then regimen 3B, which is to treat complicated TB. That's any TB that is considered to be severe disease, any HIV positive child, any TB that is in organs other than the lungs or the lymph nodes, but it excludes TB meningitis and miliary TB. These types of TB are treated with regimen 3C, which is a 6 to 9 month course. And I think even in the new guidelines will continue to be a prolonged course of TB treatment. Okay, remember that anyone who's HIV infected or malnourished does need pyridoxine along with their TB treatment, and there's some doses. And then something that I think we sometimes miss is adjusting TB treatment doses to body weight. So when you calculate the dose, you want to be checking it again a month later if they've gained weight. And then remember that rather give a half a tablet more than a half a tablet less if the guideline shows that between this weight and this weight, they should get 1.5 tablets, but they're just on the cusp of the next weight band up, rather go up than down. Okay, all retreatment cases must get the second band of treatment, but first you have to exclude drug-resistant TB. Adjunctive steroids, we give adjunctive steroids to any child with TB meningitis, any child with TB pericarditis, and then any child with severe airway obstruction. Remember that the TB that you're seeing in your younger children is often related to the lymph nodes, if they've got severe airway obstruction, either on chest x-ray or clinically, and ask about that. Often the wheeze isn't audible when you're seeing them, but when you mention a wheeze, the mom will say, yes, at night this child wheezes like crazy. Then you want to give them some steroids. We give prednisone, and the dose is a high dose because of your rifampicin. It's 2 to 4 milligrams per kilogram daily for 4 to 6 weeks. And then you're going to taper over 2 weeks. Okay, so response to treatment. And I think this is probably my most important slide in terms of the GP managing the TB patient. So you want to follow up monthly for the first 3 months. And we said in our setting that in practice, you could give the first 2 months if you're not worried about lymph nodes and they're not on steroids, mostly because our patients had to travel a long way and it often was very expensive to see the doctor. You want to accurately document the weight at each visit. It's important to remember the weight context. If a child started TB treatment because there was a TB contact, they were a relatively well child, and when you looked at their weight at the beginning, you noticed that they were following their percentile well, then that's all you expect them to do. You don't expect a sudden jump in the weight after you start TB treatment. However, if the child was severely ill and you see that their weight has plateaued or has even dropped, then you're expecting some sort of turnaround after the first month of treatment. If you don't see that, there's something going on and you need to really investigate that. We'll talk about a failed response to TB treatment now. You want to manage your smear positive kids as an adult. So you're repeating a sputum at 2 months to see if they're still smear positive. And if they are, then you're going to continue with your intensive phase. And again, you want to check at 5 months. A chest x-ray is a very poor indicator of response. So most children who have big lymph nodes when you start TB treatment will still have big lymph nodes when you check again in 2 months' time. Don't not change them to continuation phase just because you still see big lymph nodes. If you see a clinical response and you're happy that this child is getting better, you can change them to continuation phase and keep an eye on those lymph nodes. At the end of the day, there's some children who actually have to have the lymph nodes resected, but I don't know about you. That's something that's in theory for us. That's what they say, and some children just go on living with the issues with their lymph nodes because there's not really access to that care. Okay, so deterioration on treatment, or as I said, a failure to respond to treatment. First thing you're going to do is check your drug doses. Check what you prescribed. Was it correct? Check what was given. Was it correct? Check what is being given to the child by the carer. Okay, and then really importantly, check for adherence. In our setting, it is rude to say to the doctor that you're not taking your treatment. You don't disappoint your doctor. You want to make sure your doctor feels appreciated. So you tell the doctor you gave your child a treatment and you did it exactly how they said. So you really want to tease this out. And obviously this relies on us being non-judgmental and being compassionate and just understanding, and often just coming at it from the perspective of saying many people struggle with these medicines. It's hard to give children medicine. I'm not sure how many people who are in this audience are parents, but if you are parents, you know how hard it is to give small children any medication, never mind something for 4 months or 6 months. So yeah, adherence is something to really look into. Side effects, although they are relatively uncommon compared to adults, these drugs can cause quite a bit of nausea, especially INH. So ask about that. And in our setting, again, we had really restricted treatment of nausea for small babies. One of the main things that we were using was actually alcohol swabs, just getting the baby to sniff the alcohol swab, and then hoping that improves things. Check HIV status. Maybe you missed it. Maybe the HIV test was negative and it was a false negative, and now you've got a child with a TD iris because they actually had HIV. And then check if the child was previously severely malnourished. Again, maybe this is an iris picture and that's why they are deteriorating. For both these cases of TB iris, you will want to give some adjunctive steroids. And then keep thinking, always on the back of the radar, in the back of our mind is this MDR TB or not? Okay, so when do we suspect drug-resistant TB? Obviously, if there's a known source case or contact with drug-resistant TB, or a known source case who's a high-risk patient. I think it's really important to keep asking this question. I have had many children where at the beginning of treatment, it was asked, is there anyone with TB in the home? No, there's no one with TB in the home. We can't think of anybody. And then you see them at month 3 or 4 and they're not getting better. And you ask again and they say, oh yes, Granny was diagnosed with TB last month. And she had that strong TB, the drug-resistant TB. So you really want to be asking continuously, even if the patients get frustrated with us for asking the same question, we have to keep on asking, has there been a development in the home? Is there somebody with drug-resistant TB? You suspect drug-resistant TB when you have a smear positive case after 2 months of treatment. Again, look at those other reasons. It might be a compliance issue. And then a patient who relapses within the 6 months of treatment while you're giving it. A child who's severely ill and failed to respond to their TB treatment or got worse. A child who's defaulted TB treatment for more than 2 months, or there've been treatment interruptions of less than 1 month, but then they relapse and their TB gets worse. And then a child who gets recurrent TB after completing their TB course of treatment. Okay, so when drug-resistant TB is suspected in our setting, we would like to get a microbiological evidence of this. So again, that's the genotypic drug sensitivity test, called a gene expert in South Africa, although that is just a broad name for any genotypic test. And then a culture again. So don't forget your culture, again, your gold standard. And then a line probe assay test for isoniazid and rifampicin susceptibility, and then second line for the quinolones and any other antimicrobial resistance. All samples that test positive for molecular TB must then also have those samples submitted for culture. Okay, but, and this is the most important thing about this slide, don't wait to start treatment. So a child who's exposed to an adult with drug-resistant TB, as I said before, your chance of getting a positive culture or gene expert out of that child at the end of the day is low. If you wait and wait and wait to get an answer before you start treatment, you are giving that child a worse chance in the long run. So please start your drug-resistant TB treatment early and don't wait for a microbiological evidence. Okay, exposure to drug resistance cases. In our context, what we wanted to do was any child that was brought to us as an MDR TB contact would be worked up. This is obviously specifically your children under 6 years of age, but even the older ones, you can do a symptom screen on, a chest x-ray, a MAN2, and if they weren't coughing, we would get an induced sputum or a gastric aspirate. And then all children with symptoms or concerning x-rays would get a course of a co-amoxiclav for 5 days, and then we'd follow them up 3 weeks later with a new chest x-ray. And then if there's still a concern on the chest x-ray, you start them on treatment for drug-resistant TB. I'm not going to talk about the regimens here. I think we have enough of other things to talk about, but just to say, if everything came back negative, they're under 6 years of age and they're exposed to drug-resistant TB, the guidelines are to give them prophylaxis. And in South Africa, we have been using isoniazid. It's a high dose, so 15 to 20 milligrams per kilogram, plus ethambutol plus levofloxacin. And that's for 6 months. Okay, drug-related adverse events. As I said, they are much less common in children. I'm sure there are many in this room who have treated many children for TB and not seen one or seen very few adverse reactions. The most common and severe is hepatotoxicity. So if there's liver tenderness, hepatomegaly, or jaundice, you're going to do an LFT, and then you're going to treat it like you would treat an adult with a drug-induced liver injury from their TB treatment. Peripheral neuropathy may occur in your malnourished child or your child on ARVs, so don't forget to supplement with pyridoxine. And yeah, in our setting, we don't have pyridoxine in a smaller dose than 12.5. So, and there was no syrup, so children are getting just a multivit syrup. Okay, so just some don't forgets. Children who are on ARVs are going to need a double dose of their PI if they're on a PI. They might even need their PI stopped and an alternative drug given if they're on atazanavir or darunavir. And then if they're on dolutegravir, again, they're going to need a morning and evening dose of the dolutegravir. So just always be looking at the child as a whole patient and not just looking at the TB. And then check that they're actually on ARVs if they are HIV positive. And remember that rifampicin has a 2-week tail. So you want to double dose their PI or their dolutegravir till the end of the TB treatment and then 2 weeks afterwards. Again, something that I always ask my patients to do was to bring their TB treatment in with them at the end of the last month that I was going to see them, so I could see how much they'd stocked up, because there's inevitably days that are missed and you think you're covering a 2-week tail and then you see they've actually got an extra 2 weeks of treatment and you don't end up covering that tail at all. So it's good to be clear about that 2-week tail. Just another interesting fact, Red Cross Hospital, which is the main children's hospital in South Africa, looked at some admissions over a 6-month period, and 25% of their children who were admitted with acute respiratory illnesses were found to have TB later on. Yeah, and then just to remember to adjust doses against their new weight. So I think we have time to just talk a little bit about pediatric chest X-ray interpretation. Is that something that will be helpful?
I think that would be helpful.
Okay, so this is from Prof. Scarf's book, Interpreting Chest X-rays in the Resource Poor Setting. And as you can see from all the things we've discussed, at the end of the day, chest X-rays are probably going to be our main way of actually seeing what's going on inside the baby's body. Okay, so as I said, biological confirmation rates for children under 10 years of age is between 10 and 30%. So we really need something else to help us with diagnosis. So as you can see on this slide, primary TB, you can see on the left-hand side of the slide, primary TB infection, you get your Gaunt focus, and then at the top, it can go on to the lymph nodes, and then the next one down, the lymph nodes can cause an obstruction or a collapse of a lung, or it can be hematogenously spread to the entirety of the lungs, and you get a miliary picture, or to the pleura, or it can progress into your parenchyma of your lungs. Again, this could cause a pleural effusion, or you can get parenchymal disease, which could include cavitation. And then later on, you may get your post-primary TB reactivation. And that is going to look more like the adult type TB, where you see the TB in the apices of the lungs, and you get more of an adult picture on your chest X-ray. So we're not going to talk about that. We're going to talk about the children and what we're looking for on those X-rays. Okay, so the first thing, and I don't know if this is a problem for your doctors, but for us, we really struggle to get a good quality chest X-ray. So you want to first just be sure that what you're looking at is a good quality X-ray, And if it's not, you want to be clear that that's what you're looking at. You want to see that the chest X-ray is not rotated. So traditionally, we look at the two heads of the clavicles and see that they look the same on either side and that there's the same gap between them and the trachea in the middle. However, many pediatric chest X-rays are hanging children. Somebody's busy pulling up the arms in the air and the clavicles might not be equal. So it's often better to look at the anterior ribs. Just pick a rib and then look at the same rib on the other side and see that you're seeing the same distance of rib going into your X-ray, as you can see from the blue lines with the little yellow guppies on the end. Okay, so the first thing to look at is it rotated or not? If it's rotated, you're going to see things that are going to make you think of lymph nodes when there aren't lymph nodes there. Okay, then penetration. So the chest X-ray is correctly penetrated when the intervertebral spaces can be distinguished through the heart shadow. And the trachea and the proximal bronchi are clearly visible. So chest X-rays A and C are good X-rays. You can see the intervertebral spaces nicely through the cardiac shadow, and you can see your airways nicely. In both B and D, there's over penetration, and the lung fields are very dark, and you can probably picture some lymph nodes on X-ray D and some compressed airways, when actually those are not things that are you should be seeing on that X-ray. All right, here is another example. So this is under penetration. Chest X-ray A is a good X-ray. You can see your intervertebral spaces well through your cardiac shadow. You can see your airways nicely. If you look in chest X-ray B, you can't really make out your airways at all, and you definitely can't see your intervertebral spaces. Okay, you want a child to have good inspiration in the X-ray, and this you can tell by how many ribs you can see. So you want to see between 8 and 9 posterior ribs, or maybe even more. And this is a better thing to look at in your infants, the number of posterior ribs you're seeing. And then anterior ribs, you want to see at least 5 anterior ribs above the diaphragm. As you can see in this X-ray, the 6th rib goes into the diaphragm, but there are 5 anterior ribs that are well placed above the diaphragm. Okay, so again, chest X-ray A is a good inspiratory film. You can see there's 1, 2, 3, 4, 5, yeah, 5 nice anterior ribs above the diaphragm, and there's 9 posterior ribs. You can see there. Chest X-ray B is a disaster. You can see 3 anterior ribs above the diaphragm and about 6 posterior ribs. So if you look at chest X-ray B and you're not looking beforehand to see that it's well inspired, you might well think there are lymph nodes on that X-ray. You might well think that there are compressed airways, but that is not a good X-ray to be making any analysis of. Okay, so we've already looked at this picture. But just to remind you, what are we looking for? So you're looking for either your primary TB infection with your Gaunt complex. That's going to show your Gaunt focus plus your lymph nodes. Or you're looking for progression, whether it's lymph node disease that's complicated or uncomplicated, your miliary TB, you're looking for pleural effusions, and you're looking for any parenchymal disease. Okay. So just a quick reminder about the normal chest X-rays. So a 1-year-old, in this X-ray, you can see a lovely sail sign on your AP. Just a reminder that 1-year-olds have thymuses, and the thymus often is very confusing. This is the perfect X-ray where it looks like a sail sign. Sometimes it looks quite different. So you do want to look in your lateral, and on the lateral here, you can see how the retrosternal area is filled up with this mediastinum, with this thymus. Okay, so the thymic shadow is something to look for and to be aware of in your infant X-rays. And then here's a normal chest X-ray of a 6-year-old, just so you can see. So in chest X-ray A, you can see the intervertebral spaces nicely. It's got 5 anterior ribs above the diaphragm, and the lateral is probably not the best lateral ever, but there's no thymus. So it's not like your infant where you're looking for a thymus. And it's an okay x-ray to interpret. And then this is a 12-year-old x-ray. So you see how the mediastinum is getting narrower and narrower as they get older. You now have a cardiothoracic ratio of less than 50%, which is what you expect in a 12-year-old. And then you have your parenchymal tissue visible, and it's probably a nicer way to be looking for TB than the squashed up x-rays of the small babies. Okay, so your primary Gaunt focus, you're very, very unlikely to just see the focus in isolation. It's usually associated with enlarged mediastinal lymph nodes, and that's probably what you're most commonly going to see. Otherwise, you might see just the lymph nodes by themselves. Sorry, the most common thing you're going to see is just the lymph nodes by themselves and no primary Gaunt focus. Sometimes you're going to have that nice bullseye where you see the Gaunt focus and then the lymph nodes on the side. So here's a nice example. As you can see, the black arrows pointing to your Gaunt focus, and then in the left upper lobe you can see the lymph nodes that are enlarged. These are left hilar lymph nodes, and this is your classic Gaunt complex. Okay, so these are the same x-ray. There's just an annotation below. So if you look at chest x-ray A, you can see a lovely Gaunt focus again. It's a nice coin sign. They call it a coin sign, so it looks like a piece of money. And then you can see your lymph nodes, paratracheal lymph nodes on the right. And again, this is a Gaunt complex. And this is TB. You're going to treat this as TB if there's symptoms and signs of TB. Okay. Oh, don't know what happened to that x-ray. Okay, so mediastinal lymph nodes. There might be paratracheal lymph nodes. There might be perihilar lymph nodes, or there might be subcarinal lymph nodes. Subcarinal lymph nodes are present in almost all children with TB disease in their lungs. Okay, the lymph nodes look lobulated and radiopaque, so they're white or lighter than the structures around them. They can cause the shape of the hilum to be convex, bulging outwards. The usual shape of the hilum is concave. They can be more easily seen on the lateral film, and that's why we focus so much on lateral films in pediatric TB diagnosis. They include your subcarinal lymph nodes. Enlargement of your subcarinal lymph node is not always visible on the x-ray, but you often see the effects of it. So it's seen as a enlargement or fullness in the space below the carina, and as you'll see on the lateral chest x-ray that I'm going to show you just now, it's quite obvious in the bottom quadrant. Okay, so chest x-ray A is a normal x-ray. You see the concave line of the heart and the mediastinum, and then in chest x-ray B you can see how it's convex. The lymph nodes are pushing out the picture there. So those are perihilar lymph nodes on the left. Here's another example of enlarged lymph nodes. Chest x-ray A is the same as B, and it's just annotated to show you the typical convex outline of the swollen lymph nodes in the paratracheal area. Okay, so useful points about enlarged paratracheal lymph nodes on the AP chest x-ray. They cause widening of the upper mediastinum. They bulge outwards, changing the contour of the upper mediastinum, and interpretation of an upper mediastinal mass can be complicated in the presence of the thymus in your younger child. And also, please just remember that if you're seeing only paratracheal lymph nodes and there's nothing else to suggest TB, that you need to be thinking about lymphoma. Okay, so A is a normal chest x-ray, and B shows the classic paratracheal lymph nodes on the left. You see a nice widening of the mediastinum, and it's bulging outwards again. Okay, again, it's the same x-ray, just with the annotation. enlarged paratracheal lymph node, and this time it's on the right. Okay, so using the lateral chest X-ray to identify enlarged mediastinal lymph nodes, enlarged perihilar lymph nodes can sometimes be seen on the lateral form when you can't see them on your AP. Enlarged perihilar lymph nodes often give you the donut or the hamburger sign. They fill the middle of the mediastinum, whereas your thymus is the anterior mediastinum. So you can see in these chest X-rays. Okay, A is a normal chest X-ray, and then chest X-ray B, you can see that's your hamburger sign. That's a really nice hamburger sign. Chest X-ray C is just showing you what the hamburger sign is supposed to look like. And you see how the quadrant, the bottom right-hand quadrant there, is filled up, and that's not on a normal chest X-ray. You're not going to see that. So you can compare it to chest X-ray A. Chest X-ray B, C, D have a full bottom right quadrant. Okay. Here again, you can see A and B are actually normal chest X-ray. So you might look at that and say, oh, look, there's a little lymph node, but that's your pulmonary artery coming towards you, your right pulmonary artery. However, in chest X-ray C and D, you're now seeing your subcarinal lymph nodes. And again, it's filling that, this time it's the bottom left quadrant. Okay, chest X-ray B is annotated a picture of chest X-ray A, and you can see those right paratracheal lymph node and then a right perihilar lymph node. And here we're seeing the effects. So you can see the airways are narrowed. It's easier to look in X-ray A. Sorry, the airways are not narrowed in this X-ray. I apologize, that's coming now. Okay. Here you have a left paratracheal lymph node plus your donut sign. So this is the same patient. This is what the X-ray looks like on the AP, and then what it looks like on the lateral, just with some annotation. Okay, hilar lymph node enlargement with segmental parenchymal involvement. So here the lymph node is broken out into the parenchyma, and you can see some inflammation there. Because it's only one lobe that's involved, it's considered to be radiologically non-severe disease. If there's more than one lobe involved, then it's considered to be severe disease. Okay, I'm sorry, I don't know what's happened with my writing here, but you've got a really poor quality AP X-ray. However, lucky for you in this situation, you've got a nice lateral chest X-ray. You can see a really nice donut sign there, and that's enough. In the presence of TB symptoms, that's enough to say this child has TB. Okay, here's a 5-year-old. A is a normal X-ray, and then B and C, same X-ray with the right hilar opacity seen. Again, lymph nodes, and I think there's some parenchymal involvement there as well. Okay, so chest X-ray A and B. Sorry, A and B, yeah, are from a 5-year-old child, and as you can see, there's enlarged left hilar lymph node. This is a classic example where the lateral doesn't seem to show anything, but you do see something on the AP. And then here's a 4-year-old with lymph node enlargement, and the lymph nodes are actually causing a segmental opacification. So you've got some lobar involvement there. Okay, now this is what I was meaning when I spoke about compression of the airway. So here you can see the paratracheal lymph node on the right that is bulging into the chest. And then if you look carefully, it's nicer to look at the unannotated one to see that really squashed right main bronchus. And that's obviously squashed by the lymph nodes. Here again, some nice narrowed airways. They're quite significantly narrowed. And this is a kind of patient give adjunctive steroids to when you give them their treatment. Okay, how are we doing for time? I think I've still got a few minutes. Do I still have a few minutes?
Yeah, that should be fine, I think.
Okay, I mean, I can stop at any point. I think I've really said my bit. This is all just repetition. So
there's a few questions, but I think we've still got a bit of time.
Yeah.
Somebody
Okay.
thinks so.
Yeah, we still got time, so yeah.
You happy? Okay,
Yes,
well, there's
we're
just,
happy.
I think there's a tiny handful of slides left with some x-rays. So here, this has got both your bulging in your perihilar region, and you can see the airway narrowing of both your right and lateral bronchi. This is a 2-year-old. Yeah, again, there's this opacity on the lateral, which goes into the bottom right quadrant. And if you look at it in X-ray B, it's a nice hamburger sign. And then looking at X-ray A and C, you can see a really narrowed left main bronchus. Okay, this is a 6-year-old. This is quite extensive TB. I don't think I need to tell you that this one's got TB, but as you can see, lots of big lymph nodes and your donut sign. And you can actually see there's also a bit of hyperinflation with air in front of the heart on the lateral. Yeah, this child has got severe disease. Okay, and this child's got even more severe disease. So this is your classic ball valve effect. So there's occlusion of your left main bronchus with the ball valve hyperinflation. The left lung, it looks dark, everything's pushed over to the right. Again, this is severe disease, and this child's definitely going to need adjunctive steroids and probably inpatient management at first. This, if you look carefully, the right lung looks bigger than the left lung, and look how the right hemidiaphragm is pushed down. Okay, so again, this is a ball valve effect, this time of the right. If you look at the X-ray A, you can see a really narrowed left main bronchus as well. So this is extensive lymph node disease. This is an X-ray from an 8-year-old child, and this shows a left lower lobe collapse. So you see that double shadow, the heart shadow, and then you see that very white shadow underneath that. The left main bronchus, in some cases, you can see it running down more, at a more acute angle instead of going out as it should. You can't see that in this X-ray though. Here is a right lower lobe collapse, and again, this is related to the lymph node compression of that area and air not being able to get into that area. And this again is considered to be severe disease. And here is a child that has pleural disease. That's pretty obvious. Don't think I need to explain that one. Just to remember that this is something you're more likely to see in your adolescence, but this is a 6-year-old. And I think if you see this and there's any chance that this child was exposed to TB, you can start TB treatment while you're busy investigating. Obviously, if you tap the fluid, you might well get an answer with your ADA on that fluid. And then again, B is annotated picture of A. So you can see your pleural effusion. You can see the underlying lung is not normal in your right lung, and you can't see the costophrenic angle at all in this picture. So this is a 7-year-old child. Again, you've got a nice clear pleural effusion. You can tap it and see what comes of it. Yeah, obviously always thinking about other causes as well. When we diagnose TB, because we don't have complete evidence that it's TB, we're always looking for something else that might be going on. We might just be seeing a lymphoma or another cause of a pneumonia, or else cancer of sorts. Okay, here is the chest X-ray with all the things. So you can see there's paratracheal lymph nodes on the right. You can see how they're pushing that airway down. The parenchyma in the background in the right lung is abnormal looking, and then you can see your simple pleural effusion in the right. Oh, and I'm done.
Amazing, thank you. I think we've got a few
pleasure.
questions. If you're happy
Okay.
to
I am. I'm a bit doof with reading them all. Let me try.
I can read a few out to you if that's easier.
Oh,
Um,
low voice, low sound. Sorry.
I think-
sorry. Okay, yes, maybe after
yeah,
those ones. Yeah. Will you read them to me, Caroline? That'll be great. Sorry.
so there's one about how you could monitor treatment to know whether it's been successful or not. So after you've treated them for TB.
So is this during the course of the TB treatment or at the end of the TB treatment?
It's not clear, but maybe a bit of both to see whether you're going the right way.
So obviously during the course of TB treatment, your main thing you're looking for is symptom resolution. So as we said, the diagnosis of TB is based on symptoms and signs in the context of X-ray or a TST or a positive contact. So what you're specifically looking for is improvement in the symptoms and signs. And I mean, it's so clear, you know, you'll see a child who, well, it's often very clear, sometimes it's not, but you'll see a child who came in to see you and was just dull and tired all the time. And so often the mom comes back and is like, yo, this child is eating all the food in my house. And you might not see the weight gain, but you will see the child is happy and playful. Weight gain is a really good sign to look at. Yeah, as I said, obviously it's harder in a child that wasn't symptomatic, who came in as a TB contact. You did an X-ray, they had classic TB on the X-ray. Then you just have to trust that the TB treatment is working. You might not get an answer straight away. You might have to wait a bit in terms of chest X-ray resolution, but you should see X-ray resolution in a child like that. The slow response of the lymph nodes might be the thing that you don't see straight away, but you'll see the other things. Sorry, I just need to quickly let my dog out. Okay, and then at the end of TB treatment, you can do an X-ray at that point if you aren't sure if the child got better. And you should really see some resolution by that point. Like I said, sometimes the lymph nodes go on and then you're not going to see resolution, but ideally you should see some sort of resolution at that point. Is that helpful? Sorry, again, it's a picture. TB diagnosis and treatment is always a picture in children. Is that okay?
Yes, that's okay. Thank you, Taryn. And more questions there?
You want?
Carrie?
Do you want to
Another
add
one?
anything, Dr. Sunny?
No, I'm okay. Thank you, Taryn.
Okay.
No, I think that was a really good explanation and really clear. There was another one about, there's a few questions about cervical lymphadenopathy and how you can tell the difference between a cervical lymphadenopathy that's caused by, say, a multi-drug resistant TB or EB virus or another cause. Is there anything you can see there that's different?
Okay, so obviously chronicity, a child who has an EBV infection, their lymph nodes are going to resolve over time, whereas if it's a TB infection, they're going to progress and sadly they might go on to become a scrofula or something more severe. The TB lymph nodes are often matted. They are not always smooth and nicely rounded, although they often are there too. I would say in any child where you're suspicious, if it's possible, you should try do a FNA and just get an idea of what the tissue looks like in the lymph node, and then you can decide from there. But the main thing I think is the chronicity. The interesting thing I found is that children with TB lymph nodes often present quite a bit later. So when you ask, then it's actually been there for quite a long time. And I think it's because it starts small and they're so well at that point. By the time they come to you, it's been there for quite a long time. So that's obviously helpful. And then a child who's got lymph nodes who has the TB contact, there's a high chance that those nodes are TB, and that's actually enough. If those nodes have been there for more than 2 weeks, that's enough to say they most likely have TB.
Great, thank you. I think that was also a really good explanation. Any other questions? There's a few more in the chat, but just if anyone else has another question. Okay, so the next one was about rifampicin. It was just a bit of clarification. I think you said it had a 2-week tail, and this might just be a terminology question, just as in, yeah, what was meant by that?
Okay, sorry. So I'm trying to unshare my screen here. Sorry, I'm very doof with this. Never mind. Okay, so rifampicin sticks around in the blood for a long time. Its half-life or its tail, I don't know what's the pharmacological word for that, is 2 weeks. So if you've been on rifampicin and you stop it, there's a 2-week window where there's still rifampicin in the blood. If you are giving ARVs that are affected by rifampicin, you need to continue double dosing your dolutegravir or double dosing your PI for that 2-week after you've stopped the rifampicin. Does that make sense?
Yes, I think so. I think that makes sense.
You can re-explain it if you want, Caroline, if I have.
No, I think that was a good explanation. It's definitely, yeah, it makes, I think it's basically the rifampicin is there for another 2 weeks after you've given the last dose.
Yeah.
And you have to consider that.
Nicely, thank you.
Yeah, no. And then there was another one about just cervical lymphadenopathy. I think just about whether you need to do chest x-rays for anyone who's got cervical lymphadenopathy. And if that's your only symptom in an asymptomatic child, how suspicious, I guess, do you need to be?
Yeah, good question. Actually, I should have said that earlier. I would definitely do a chest x-ray in a child with cervical lymph nodes. So often it's going to give you a slam dunk answer. I've got a few children where we were umming and ahhing about these lymph nodes because they just felt like your classic viral lymph nodes. And we've done a chest x-ray and there it is, a nice hamburger sign or a nice big lymph node sitting in the hilum. Or even parenchymal disease. If you've got parenchymal disease with cervical lymph nodes, then that's probably TB. There are not too many other things that are going to give you lung tissue plus cervical lymph node infection.
Okay, great. I don't think there's any more questions in the chat. Oh, wait, no, we've got one. One could just come through. Which is just about the role of gene expert in children with multi-drug resistant TB. Sorry, the role of gene expert in children who have parents who have multi-drug resistant TB.
Okay, so definitely. I'm not sure, was that in my slide about drug resistant TB? Absolutely, gene expert is your investigation of choice because it's going to give you an answer pretty quickly. However, if you've got a child who's got a parent who's got proven drug-resistant TB, and you do a gene expert and it's negative, but they've got symptoms or they've got chest x-ray changes, they must be treated according to their adult contact. I have always discussed these cases with Professor Scarf, who is world expert on. I've had a few cases where the parent has proven drug-resistant TB. We've done a gene expert on the child, and the child's resistance has come back as sensitive. And even in those cases, you can start them on drug-sensitive TB treatment, but you watch them very closely because they might have a mixed colony, and you might just have seen the one side of the colony and not the other. So you might even, in that case, start the child on drug-resistant TB treatment. Sorry, and so your question was about gene expert. You definitely want to do the gene expert in the child because that's going to give you an answer straight away, and then your LPA are on that as well. So you can start with your gene expert, you'll see your RIF resistance, and then you can ask the lab to do the LPA after that.
Okay, great. There aren't any more questions in the chat. Sunny, do you think that's probably time, or are there any other questions out
Yes.
there?
Probably ask one of the GPs. Second, so make la alam di siaro TB experience theyကြောင့်နည်းနည်းလေးပြောပြမှာဘယ်လိုနေလဲတခြား GP တွေလည်းသိအောင်လို့မိတ်လာမှာဆရာတို့ TB ဘယ်လိုအခြေအနေရှိလဲမသိဘူး I'm just asking one of the GPs for the gentleman, the GP who asked about Gene Expert, about their experience of
Yes.
TB in Central Myanmar. So can youပြောလို့ရမလားမသိဘူး Yeah, we're not having anybody on this experience of TB in children and younger.
Certain of your
ပြောပါမလွယ်ပြောပါ
really. In English or Burmese?
ဟိုလို English နဲ့ပဲပြောလိုက်ပါလားမလွယ်မယ်ရပါတယ်နည်းနည်းလောက်ပြောလိုက်ရပါ
I'm a fee coordinator of MMA TB project, and in our fee, there is a childhood TB is not, I mean, not very common, but there is some patients, some childhood heads, most of them are extrapulmonary TB, and some are primary complex. We diagnose childhood TB on the clinical judgment and chest X-ray and not doing sputum gene expert. If we need more than 8 years, we do sputum examination for microscopy, and then if needed, gene expert. Most of them are EP, so they do not need to do sputum examination. But for some patient, they have connect with HIV, mother or father. So one child is HIV positive and sputum positive. But positive bacteriological confirmed cases are slight rare, and most of them are extrapulmonary childhood TB. Very rare TB meningitis. We cannot done tuberculin deaths. It is not mentioned in our guideline, WHO guideline. That's all, sir.
Thank you Malumeru. Thank you.
Yes.
That's yeah, I'm quite surprised because when I was a medical student in Myanmar, we were doing tuberculin tests, but now it's probably not done now. Okay. Thank you.
Can I ask
So
you, when you
then-
say extrapulmonary TB, are you talking about TB lymph nodes or outside of the chest?
Some cervical lymph node are most common. Others are TB bone. TB bone. Some patients have TB spine, and this is very rare. And one children, he got TB calcaneum. When her grandmother noticed the child cannot walk properly, so X-ray of the foot, it has a tuberculoma scene, and orthopedics diagnosed as TB in the bone.
Wow.
And some extrapulmonary TB are rare for TB abdomen in childhood. It is most common in the adult with HIV positive, but in the childhood, TB enteritis is rare.
Thank you.
Thank you very much, Malveru. That's very useful to bring things into a context.
In Medila, we have 10 to 20% of all TB patients are childhood TB. We diagnose at under 8 years, or child only in chest X-ray. We are difficult to make a culture. So we have a gene spot for MDR-TB, children of MDR-TB patient, such as gastric lavage. If no rifampicin resistance, so we give only anti-TB, not or MDR-TB treatment. Over 8 years, we get a student examination for all children.
What
So
drugs
you
are
can
you
do-
using?
Microscopy.
Microscope.
No,
Well,
no.
what
What
drugs are you
are you
using?
using to treat the TB?
Pediatric drugs and combined drugs. Rifampicin, isoniazid, and ethanbutol.
3HR for 2 months and 4HR, 4HR, HR for 4 months.
Okay, and PZA? Pyrazinamide?
Pyrazinamide for initial treatment regime.
Okay.
Yes.
What is the drug supply like nowadays? Can you still get the anti-TB drugs? So
NTB from NTB, we get anti-TB drugs for all skin treatment.
National Tuberculosis Program. We got
Okay.
TB drugs.
Okay. That's great.
From DOT, DODS from PSI.
Or DODS from
Doctor.
PSI. All are
So PSI.
collected from
Organization
NTB.
Service International.
Directory directly of the short treatment course.
So PSI is like an NGO that provides anti-TB.
It is from US8.
USAID. Right. Thank you very much.
I'm
Any
sorry
other
if I'm not
comments,
responding.
Kira?
I'm struggling to hear.
Carrie, any more comments from you?
There's no comments here. I had a bit of a question. So my own experience in TB of the UK is we have very few cases and we have lots of resources to manage them. But one of the biggest things that we do is teaching children to swallow tablets at younger ages, and putting a lot of effort into making sure that they're followed up and that they take all of their tablets, which I appreciate is not possible in lots of areas. But I wondered whether that was an approach in terms of getting younger children to swallow tablets in something that you do, or they just do it in places.
In South Africa, the TB treatment for the smaller children is dispersible. Is it the same in Myanmar?
Yeah, cancer TB treatment liquid form နဲ့ရလားဒါမှမဟုတ် tablet form နဲ့ရလားကလေးတွေတက်က
Tablet absorbable
tablet. Yeah,
tablet,
disposable tablet.
disposable tablets. Okay, that's good.
Okay.
That makes it easy.
Thank you. I don't think there's any more questions in the chat. Is there anything else? Or is it time to wrap up.
Yes.
I
like to
want
say-
to send a link to that TV atlas, because there was a bit of stuff I took out. It was a lot to get through, but I would like to send the link for people to refer back to. It's a really good resource. Can I do that?
Okay.
Sounds great. Yes, please.
Yes, you can. Okay. Thank you very much, Dr. Gaunt, for giving us your time and your expertise. And I hope I learned a lot as I practice in a part of the UK where we don't see much TB cases. And I hope as this webinar is recorded, Myanmar GPs can revisit it again and check things out and use it as a resource for the future. And we're planning at present, this is on a Facebook, but we're planning to set up a website with the help of Caroline. So hopefully they'll be on the Myanmar GP education website in the future. Thank you very much, Caroline, for organizing it. Sierra Alon Gulo organize the Myanmar GP education or let's use it tomorrow. Gulo chain baby day out there to the Alon or let's tomorrow. To the TB John, Shimpia Doris, Yama, Memeru, yes, ya Kinso, yes, ya Muto. Okay. Alon Jesu.
Thank you very much, Taryn.
Thank you.
Yeah, thank you, everyone.
Thank you.
Thank you.
Thank you.
Nice to meet